So, hello, I'm Gloria Hall, editor-in-chief of Chiropractic Economics. I'm excited to have with me today Dr. Christopher Proulx, Vice President of Clinical Affairs and Strategy at Medray Laser and Technology. Dr. Chris is here today to discuss his recent article, Nutrition, Neuroprotection. Dr. Chris, welcome.
Thank you, Gloria. Very much appreciate you having me on. I look forward to chatting with you.
Yes. Before we get started with some questions, can you tell us a little bit about yourself?
Yes, so I am a chiropractor. I actually started in clinical practice as a exercise physiologist and kind of throughout going on and doing some additional graduate work before chiropractic as well. That's kind of what got me involved. And then even when I got out, I was involved in education, postgraduate education, research. I've been in multiple clinical practices and own multiple clinics. So I'm also still involved in active clinical practice on top of that as well. And still teach on occasion. So I teach biomechanics, and my other area of interest is in neuromechanics and biomechanics. So it does kind of overlap there.
All right, excellent. All righty, so chiropractors often see patients with early neuropathy symptoms before they are formally diagnosed. Why is this condition becoming more common in conservative care practices?
Well, there's a few, sort of layers to this to really sort of unpack. One is looking at the population in general that typically is going to experience this peripheral neuropathy. So often they're a little bit older, and that's just because of sort of that temporal dimension that as we've had something long enough, it starts to rear its ugly head like some of the other conditions we might treat, like osteoarthritis and things like that. Um, but even then, it's a very sort of multifactorial condition where it involves some of these other issues, like many of us tend to see. So diabetes being one of them, and often attached to diabetes is this metabolic syndrome. And so the statistics are, for lack of a better word, sort of staggering. So we're seeing, that result climb with regards to diabetic problems and diabetic diagnoses. So there's a
Okay.
very large percentage of the population that has it. They typically are slightly older, as we identified in that first point. And because we tend to see a lot of people with comorbidities and multiple problems within our clinics because we often take care of multiple things. And then often associated with why some people may have gotten a metabolic syndrome or diabetes is related to the nutritional side of things. Constant, increases in the amount of carbohydrates in particular, and then being sedentary, because our biggest pool of where we'll store those carbohydrates is in the muscle tissue. And when we're sedentary, we don't metabolically manage our blood glucose levels appropriately, which is kind of that early key factor that we look at in terms of, how we're diagnosing this particular condition. And so a lot of patients will show up for other things that are more at the forefront that they think about, which is going to be pain. A lot of patients that are experiencing peripheral neuropathy, diabetic peripheral neuropathy, may not be experiencing pain. It could be some numbness, could be some tingling, and it's not at that forefront. So they're like, oh, I want to take care of the worst things first. But because of these comorbidities that often present, because someone with low back pain may also be sedentary, right? So we start to connect those dots. And so that kind of brings us to, sometimes you don't know until you ask.
Right. Such a problem with our aging population for sure.
Yes.
Why do many conventional approaches to neuropathy fall short?
So as a result of sort of being that multifactorial condition that is causing this peripheral neuropathy, it's very challenging to kind of look at it from the perspective of do this one thing, do this other one thing, where there is this, sort of overlap. And so For example, because it is related to that person who is likely diabetic, oftentimes they're being controlled. So one of the first lines of defenses is after someone's been diagnosed with type 2 diabetes, even the pre-diabetic, is they may be put on a medication. So metformin, for example, literally reduces the body's ability to produce the energy oxidative, which is utilizing that oxygen in a good way. So it's almost counterintuitive to what we're trying to accomplish. And so we need to sort of look at the impact of both the condition, but also some of the other ways that it's being managed. And again, that big one is going to be the oxidative stress, because um, that oxidative stress, which is a fancy way of saying when we breathe in oxygen, are we using it appropriately? And really, it's to produce this, chemical energy that we use for many things inside of the body. Um, but when we don't utilize it and we prepared it to be utilized, it can actually become a negative thing for us. And so those people's ability, one, to not use it when we prepared it, and two, the downside of what happens as a result of that is basically what we're seeing is this peripheral neuropathy. So the approach is going to need to be multifactorial. So we need to deal with those different layers. One is, how can we improve the oxidative stress? How can we influence this dysfunction with regards to the metabolic syndrome? Um, and then, the peripheral neuropathy in and of itself, that sort of pathophysiological process, is there's this microvascular compromise that basically is what causes the destruction of these nerves. So then we also have to look at and deal with the flow of microcirculation, and then reverse that effect, which was the sort of destruction of those nerves. And so, and that's part of the challenge, is people typically associate bad things with pain, but they don't necessarily present with pain. And that sort of first indication is going to be this numbness, tingling, maybe some balance issues, maybe some other things. And so, because the cause is multifactorial, the treatment is also going to have to be multifactorial.
Excellent.
Your article discusses combining regenerative technologies such as laser and shockwave with targeted nutritional strategies. Why do these approaches work well together?
So I often use the analogy of restoring an old house or building, right? And so many of the components of maybe that old building need to be taken down, and then not only just taken down, but they need to be removed, because maybe there's a really good foundation and we need to get to that foundation and build from that foundation up. We may need to fix some of that foundation. And so when we look at the impact of nutritional strategies, think of that as sort of the building materials, right? So that's, maybe your big box store bringing the wood and the stone and the cement and the wires and all of those things, but someone needs to put it together. And so that's where, the human body's really good at kind of doing that stuff. But again, let's think back of why they have this problem to begin with. And there's a lot of compromise. They don't seem to have the workers to, take those materials. And so that's why the nutritional strategies in and of itself on their own may not be sufficient. And then likewise, I can maybe use some of these building opportunities and bring the workers, but they don't have the materials. And so together we are providing the ability to get rid of the stuff that the body shouldn't have in that area anymore, part of the immune system. So increasing the energy that the body's going to utilize as a result of that. That's that ATP, adenosine triphosphate, increasing the microcirculation. So that could be, nitric oxide, which helps to open up the vessels, improve the circulation to the area, which is the delivery mechanism for that stuff. And then we think of, well, who's going to build it? And that's where some of these other regenerative pieces come in, like shockwave or laser. And that, again, it's exogenous, so it's outside the body. So we're still relying on the body's ability to do stuff. And that's where the signal processing from these types of regenerative approaches assist in taking those building blocks and sort of potentially reversing and then rebuilding. And so we call that regenerative medicine, which maybe some people think of on a different level like aesthetics, but regenerative medicine, it's rebuilding some of those things. And yes, it could be skin.
Yeah,
um,
for sure.
it could be joint structures, the cartilage, the fluid inside of there. Um, but probably pretty important is going to be circulation and those nerves. And so together with the nutritional support that provides us the opportunity for the body to function, optimally, provide the stuff that's necessary
Right.
for the building blocks, in addition to those regenerative approaches with exogenous forms of energy like shockwave and laser, help to really push the body, because that actually creates the stimulus that otherwise, if you think about, again, one of the factors associated with these people being sedentary or at least not being as active, they're going to need a little bit more assistance in pushing that body in the direction of creating a stimulus that causes an adaptation.
Which nutrients show the strongest evidence for supporting peripheral nerve health?
Oh, so there's a lot. But that's kind of the problem too. And the way I look at it is where a lot of my colleagues, and not that we don't spend a lot of time, in the physiology or the nutrition, but more on the neurology, more on, the biomechanics and things like that. And here's what we know, Gloria, is if I give a patient 10 things to do, they may do zero. And the reason is because studies have shown that they're probably only going to do about 3 to 5 things. And the mentality of a patient is I give them 10 and they think, well, if I can't do 10, then I'm not going to do any. So they don't just choose the top 3 to 5. And so we need to be careful. And as much as it's as simple to say, well, eat really well. And that can be part of that shift. But in there are some, assistive supplements, and as many, there could be as many as 30 that might be helpful. But some of the biggies like alpha lipoic acid. So, and I call them biggies because there's a lot of evidence behind them. So the alpha lipoic acid can be really important at sort of setting the stage for um, tearing down that old house, that old structure. And how it does that is it can improve circulation. It improves the body's ability to react to when we don't use the oxygen appropriately. It's going to assist in that process, because when we don't use oxygen appropriately, it actually becomes a free radical, which is a bad thing. So it assists in being an antioxidant, but what's cool is it actually assists in rebuilding some of those other antioxidants, which we might also get in food where otherwise maybe they weren't working as well because they didn't have the supportive mechanism associated with that. And so those are the alpha lipoic acid, I think, is one of the most well studied and well supported within that area. Also helps to reduce inflammation. Also helps to improve nerve conduction velocity. So what I just did is in a really fancy way. It's like I just ticked. I can't tell you how many boxes that are associated with peripheral neuropathy, diabetic peripheral neuropathy. Um, I think another one is uh, augmentatine. Augmentatine is a very interesting one because a lot of these patients, if they have been seen by someone else and we may not be their first line, they could be put on something like, a gabapentin, which ironically, a lot of the side effects of gabapentin, it can be helpful, but a lot of the side effects are actually neurological deficit as well. And so
Oh, wow.
that seems counterintuitive or counterproductive, where augmentin can assist and be really good at reducing those abnormal sensations that they get, such as the tingling, the numbness, and things like that, because it acts more as a neuromodulator. It acts very similar to why someone might be on something like gabapentin. Methylated B vitamins, I think, is another really important one, and the reason for that is that's kind of that backbone with regards to the metabolic activity as well. So the alpha lipoic acid may assist in, you know, reducing the negative effects of not having really good metabolic activity, increasing the opportunity for the antioxidants and reducing pro-inflammatory mediators. And all of those things go back to my sort of analogy where, um, tearing down that house, if no one's there to clear it away, we can't just build on top of that. And so that's where the B vitamins might come in and assist in that metabolic activity. And we can measure some of these levels too that actually will tell us and say, listen, you are low in these B vitamins, and so we're really able to also justify that application. And then another big one is going to be omega-3 fatty acids. So they're pretty easy to take, and sometimes you'll find them combined. Two, they're not overly expensive. Three, they give you a lot of bang for your buck. So you're not adding to, because here's the other problem is many of these people are on what we call a brown bag of medications. And so, maybe they're on 10 different medications already, and you're going to ask them to take 20 of those things that I might find beneficial. Go back to the 3 to 5 and think about, what's going to do and give you the biggest bang for your buck.
Good tips. Thank you very much. What is the biggest clinical takeaway for chiropractors treating patients with neuropathy?
Oh, they're already coming in. So, studies have shown that somewhere around 15 to 18% of the patients that we're already seeing have diabetic peripheral neuropathy. And so they're already coming in the clinic. And here's, as I like to tout as a chiropractor myself, that we have a lot of, really cool opportunities because we tend to have people stick with us after we've, really kind of helped them with their primary condition. And sometimes we may miss something if we don't ask. So we need to ask and make sure, by the way, we can manage this. And so there's some really unique opportunity because they may only be going to their primary care physician for that management of the diabetes, where they might be on metformin. God forbid they actually convert and they go from being a type 2 and a type 1 diabetic simultaneously, which can happen. And so, like I said earlier, metformin is it's important in the management of type 2 diabetes, but it's not without its compromise too, which is the downside and actually some of the precursors associated with diabetic neuropathy. So we have a very captive audience, so we can recognize earlier symptoms. We can screen really, really well because I feel like we're pretty good with neurology. And so screening for those patients is not overly complicated. A simple filament test is a great way to do that. A tuning fork, things that many people already have in their office. We've already done a history and an intake, so we know that there might be some compromise with regards to their nutritional intake as well as their lifestyle being sedentary. And so a lot of overlap in maybe they came in for low back pain is we're going to utilize very similar strategies. And so we can actually sort of co-manage that condition simultaneously because, by the way, if the diabetic peripheral neuropathy is what's causing their abnormal gait pattern that's causing their low back pain, it would make sense that we would want to make sure that we can address that. And then there's beyond that too, is how many people out there are walking around with this condition that are not getting managed at all, or they're only getting managed, through a pharmaceutical intervention. And we know that we have better opportunities that we can implement to do that because, we have a really captive audience. We probably have better compliance. We're better at getting patients to come in more regularly. Like you don't go see your primary care 3 times a week,
Right.
but yet we're really good at that. And that's kind of what it takes to reverse that. And I don't know if I can say this or not, but on a side note, we're having a discussion at home. I have a seventh grader son and an eighth grader daughter,
Wow.
and someone brought up the question and said, "Oh, can can diabetes be reversed? And my daughter jumps in and she's like, no, it cannot. I said, where did you hear that? She's like, well, that's what we talked about in health class. And I said, well, that's unfortunate because that is actually not true. With appropriate interventions and especially creating that compliance, it is a lifestyle change, but they need help, just like everything, right?
Right.
Even like my Tom Brady, one of the best quarterbacks has a coach. So people need coaches or people need people in their corner to help support them.
Right.
And that's where I think we come in because we're really good at talking to patients about lifestyle. We're really good about talking to getting patients in and explaining what it is that we have to offer. I believe studies still show our best opportunity to get new patients is still direct to consumer. And so we're really good at messaging those people and explaining to them, you have a problem that we can actually help you with.
Excellent. Dr. Chris, thanks for being here today and for your
That's
continued
right.
support of chiropractic economics and the profession. This was a great discussion. Appreciate your
Well, I
time.
I thank you too, Gloria, individually, but also Chiropractic Economics to really help the profession to keep us moving forward, which is hugely important because as we can do better as a profession, it means we can help more people. So it's a win-win-win.
It's a win-win. Thank you so much.